Hi guys, it's Martin from In the Mess. Today we're going to talk to you about acute limb ischemia. Acute limb ischemia is a rare but devastating pathology which presents when there's a sudden occlusion of a blood supply to a limb, normally the leg, and this leads to a threatened limb which needs to be treated urgently. This is usually under a 2-week duration, as anything over a 2-week duration is classed as a critical limb ischemia and is managed very differently. Acute limb ischemia is normally caused by an embolic or a thrombotic event. Embolic events include AF, rupture of a plaque from a AAA, or from a cardiac cause such as MI or arrhythmia. Thrombotic events include acute on chronic limb ischemia, knee dislocation from an intimal injury from where the knee is tearing against the popliteal artery, and a popliteal artery aneurysm occlusion. First of all, let's recap some anatomy. Here you can see the aorta coming down the abdomen, giving off its visceral vessels and the renal arteries. Below this, at roughly the level of the umbilicus, it splits into the iliac arteries. These then split into the internal external iliac arteries. The internal iliac artery supplying the pelvis, and the external iliac artery becoming the common femoral artery as it comes under the inguinal ligament. It then travels for a few centimetres as the common femoral before it gives off the profunda artery, which dives deep down into the thigh and supplies all the muscles of the thigh. The superficial femoral artery runs on the inside of the thigh and goes through at the adductor canal on the medial aspect to go behind the knee to become the popliteal artery. Below the knee, the popliteal artery gives off the anterior tibial artery, and then below that splits into the posterior tibial and peroneal arteries. These are where you'll get your foot pulses later on. You can get occlusion at any of these sites. However, there are some common areas that we need to think about. Most devastating is at the level of the aortic bifurcation, and this can create a saddle embolus which cuts off blood supply to the pelvis and both the lower limbs. This is life-threatening. Another area where you can get an occlusion is at the level of the inguinal ligament, where the external iliac artery becomes the common femoral artery. This is a common area and quite easy to treat, which we'll discuss later. Further down the leg, you can get occlusion at the popliteal artery, commonly due to a popliteal artery aneurysm, and more distal to that, which isn't very amenable to surgical treatment. Now let's talk about how you assess a patient with an acute limb ischemia. So first of all, you'll be called to see somebody with an acute limb ischemia, normally presenting with pain, but this isn't always the case. You need to take a full history and examination of the patient. This should include significant vascular history, such as recent MI, new onset AF, and also any history of peripheral arterial disease, and this will become important when we're talking about treatment plans later on. When examining the patient, you should take full peripheral pulses. This should include femoral, popliteal, dorsalis pedis and posterior tibial pulses. If any of these are absent, you should also then use a Doppler to assess for signals. If there are pulses absent, you may still get signals which would show that there is some blood flowing in that artery. We'll do another video talking about peripheral vascular examination and Doppler signals, as it can get a bit complicated. Now we've done our examination and I've taken our history. We now need to put that together with the classical history of what is an acute limb ischemia. So you're looking for the 6 P's of an acute limb ischemia. They are pallor, pulselessness, paresthesia, paralysis, pain, and perishingly cold. Some of these may be present, some may not. It's uncommon to get all 6. However, if you do, it's likely that it's too late for that limb and the patient may be heading for an amputation. So we've made our provisional diagnosis of an acute limb ischemia. What next? Arrange a CT angiogram urgently. Talk to the consultant vascular surgeon on call, but also talk to the anaesthetic team. This patient may need to go to theatre urgently. Start the patient on IV fluids, keep them nil by mouth, but these patients are likely to require IV morphine to settle the pain down. Other investigations you should do include blood tests, including a full blood count, group and save, as the patient may lose blood in theatre, and use needs, particularly a CK, as they may be undergoing muscle death and have an acute kidney injury. So how do we treat an acute limb ischemia? If the patient has no previous history of peripheral arterial disease and a true acute limb ischemia, for example from an embolus from AF, they need to go to theatre urgently to have this clot removed. If this clot is lodged within the femoral artery, what we would do is we'd do a cut down to the femoral artery in the groin through about 5 to 7 centimetre incision. We would control the artery, both inflow and outflow, make a hole in it, and then use a Fogarty catheter to pass beyond the clot, inflate a little balloon and pull it back. It comes out as a nice wiggly worm. One of the most common metabolic consequences is a sudden hyperkalemia, causing cardiac instability. That's why at this moment in time, communication is everything. What next? This patient's leg has been without oxygen and blood for 8 hours. What happens when muscle gets a new blood supply is it starts to swell. The damaged cells swell up and they're tightly confined within compartments of the lower leg. This can lead to a compartment syndrome. So quite often, the surgeons in theatre will make a decision to do fasciotomies. Even if the patient doesn't need them at that time, 2 hours later, that leg will swell and you'll be bringing the patient back to theatre. So it's good to think about doing those early. Do you remember those patients we talked about earlier who have peripheral arterial disease and an acute limb ischemia? They're slightly more complicated. The operation that we've just described doesn't work for them. This means that we can treat these patients conservatively with anticoagulation. Most consultants would use heparin or deltaparin in split dose. Unfortunately, in both groups of patients, sometimes it's impossible to revascularize the leg and these patients will have to have an amputation. The site of amputation depends very much upon where the occlusion is and how much other blood flow they have going to that leg. There we go, there's a quick roundup of acute limb ischemia. The things to remember are the patients that are at risk, those presenting with a painful leg who have AF or other signs of embolic disease, and it's important you act early with imaging, referral to the vascular team, and getting anaesthetics in early if you think they're going to need to go to theatre. Don't forget to like and subscribe so you never miss a thing.